Well, ALL has been just a fabulous disease to be involved in. Up until a few years ago, in the adult setting at least, we were always very discouraged that our response rates were very low as opposed to the outstanding success that our pediatric counterparts have been having with this disease. We're now, over the last few years, been seeing a huge explosion in therapeutic options for our patients. First of all, there's been the development of antibody therapies. The approval of blinatumomab, a bispecific antibody which activates the immune system in refractory relapse patients, really was an advance. It was approved a couple years ago. Data published this year with another conjugate, inotuzumab, which is a CD22 antibody drug conjugate, is really leading the way for that antibody to be approved by the FDA hopefully later this year. And of course, there is all of the excitement about CAR T-cells, adoptive T-cell therapy. And I think this ASH saw, again, a profusion of abstracts from various groups. It seems like every center is developing a specific chimeric antigen receptor T-cell using different constructs, different approaches. We even saw CAR T-cells sort of leaking into other diseases. So there's a huge amount of enthusiasm with a lot of these new CAR technologies. I think we're going to be seeing this sort of enter into the mainstream over the next few years. But there is a word of caution. Right before this meeting, the FDA put a clinical hold on one of the leading candidates for CAR T-cell therapy for ALL, the Juno CAR T-cells, because of a couple of patient deaths. So, I think our enthusiasm for that, at least that modality, has to be tempered by the realization that there's still a lot that needs to be done. But the number of sessions talking about adult ALL, the enthusiasm for developing combination approaches with these new antibody drug conjugates is really palpable.